Hello, everyone. Our next speaker today is Jared Williams, giving a talk titled Using AI to Determine Correlations in Underserved Hypertension Patients. Jared is the Chief Financial Officer and SVP at AccessHealth. He began his career at Seton Medical Center in Austin, Texas. While there, he worked in the IT, analytics, and finance departments. He also worked for Houston Methodist Gulf Coast Health Center Incorporated and Harbor Healthcare Systems, where he grew in the areas of finance, accounting, and data analytics, serving as the controller and chief financial officer. Jared is passionate about data analytics, finance management, and using information to improve process improvement, forecasting, and assessing trends. Please join me in welcoming Jared to the stage.
All right. Hello, everyone. My name is Jared Williams. I'm the Chief Financial Officer at AccessHealth, and today's presentation will be titled Using AI to Determine Correlations in Underserved Hypertension Patients. So just a brief overview of what this study will be about, this presentation. It was formulated in a research in my DBA program, but I put it out in slide form. We're going to kind of follow this format and use it as a guide. So the study overview in the background. This study is very significant when you talk about AI and underserved populations, low-income urban communities. But what's bigger than AI and what's in junction with AI is the social determinants of health aspect of it, the ethnogeriatrics, the social economics, and studying these patients who really don't have a lot of access to the basic needs that majority of Americans have access to. So NAC, which is the National Association of Community Health Centers, partner with the American Heart Associations as well as the YMCA to kind of guide this study before it was released to federally qualified health centers like the center I work for in Richmond, Texas. Because patients had a lot of comorbidities, they were seen to be a perfect fit for this study, as we wanted to determine if AI really did diminish the health crisis in the underserved community. So before I move on, just a little bit about AI and healthcare. There's a machine learning and a deep machine learning, which one is like a brain, the other one uses the ER. We're using the most basic form just due to the type of patients we serve. Some key terms, just to go through a lot of jargon, because in the healthcare sector, you can use jargon that can really confuse you. So it would be hypertension, controlled and uncontrolled. The 140/90 below is controlled, over is uncontrolled. I'd be saying words like SMBP for self-measured blood pressures. Some words that are coming up a lot are social determinants of health, SDOH, ethnogeriatrics, which focuses on the growing diversity of older patients in healthcare. So this is a study that I kind of threw in there that kind of have a lot of correlation between AI and underserved communities. Compliance, is the patient coming to the appointment on time? Are they taking the medications on time? Food insecurity, which is one of the biggest aspects being looked at right now. Does the patient have an adequate amount of food that they can survive on that meets their basic needs? You'll see a term like federal poverty level, which kind of goes into what the HHS with the Health and Human Service kind of guides to let patients and people know if you fall in a certain category, you are a percentage below the federal poverty level. Using analysis, we use terms like multicollinarity and heteroscedasticity, which kind of tests both the variance and in these data aspects and the occurrence of intercorrelations. Theory of planned behavior will be also used in this presentation to kind of gauge what would a patient do when they were given all of the information. So the problem The problem we have is when COVID hit, the pandemic played a major role on not just everyone, but underserved and low income and the vulnerable populations. Patients were losing jobs. They were unable to come to appointments because a lot of them lived in a term we call ALICE, asset limited income constraint employed, which is one set of tires away from being able to afford uh, the basic needs or going homeless. So a lot of these patients were complex patients. They didn't come to the appointment, and we found that a lot of the patients did not engage in any type of AI. So while this quote is 25%, in our system, we can say about 95% of patients did not even engage in a form of AI, which is telehealth or any type of monitoring to increase their health disparities. So the method used in this study, basically taking the AI SMBP devices and running that against factors to kind of get a correlation to prove or disprove if AI did help with each of these types of variables. I used a multivariate analysis, regression analysis to kind of determine if there was a statistic significance within each of these types of variables. Pre-data, post-data was collected. I used Stata for my collection method. Variables, blood pressure levels, of course. This is using the AI technology and predictive technology. Socio-economic factors. We pull the individual's federal poverty level as well as their insurance status, if they were insured, uninsured, were on any type of plans, their social determinants of health, where they lived, if they had access to adequate food, cultural backgrounds, their age, race, ethnicity, and gender. Of course, you know that when you talk about hypertension and you talk about AI, they're always geared towards one of these: age, race, ethnicity, and gender of patients, and the compliance, the nutrition. Within the new AI technology, you're able to log your food in. You can look at your smartphone without a cuff and be able to get a predictive analysis if you're going to be out of a range or in a range. So a lot of these factors are being played just to really understand this complex need of our patients. When we talk about the participants, all participants were 18 and older. Um, their blood pressure levels had to be out of compliance. So over 140 over 90, they had to agree to these AI technology platforms, being able to take multiple blood pressure readings, as well as downloading the smart app on their smartphone. And the demographics, as you can see, it's a 60% Hispanic, 30% African American, 10% with white and other. So we had a heavy Hispanic and African American population that looked at and joined this study for artificial intelligence and trying to decrease that hypertension rate. So before we can even run the data, we had to do some testing of the data to ensure that the data was not compromised. There were no false correlations within the data, as well as aspects, jobs, so that we did not have any type of inflated numbers. So we did look at the VIFs, so the various inflation factors, and we use steps just to kind of see if our data was in fact true and not inflated. The results from that was everything was under 4. So that means we did have true data that was not inflated, that was not going um, off the Richter scales, if you want to say. So we did have a really good result on that. Using that heteroscedasticity number and that figure, we wanted to make sure that our data was consistent. So when we looked at the testing for that, we did determine that the data was consistent. It was one or two outliers, but those were patients with really high blood pressure readings. But the data was very, very consistent. So the research questions that we chose to test, as well as the hypothesis testing, we looked at the relationship, and this is the meat of the study, of socio-economic factors on hypertension patients using these AI devices. So we tested the null and the alternative hypothesis to see if there was any type of correlation. And we found that the federal poverty level over insurance had a lot to do with how the patients responded to the AI technology, as well as if they were going to fall into the compliance after using the AI technology. So what that says to us is that no matter if the patient was very poor or had money, um, they were able to make an impact versus patients who had private insurance, marketplace insurance, Medicaid or Medicare, which speaks a lot to a lot of the areas in this study. So going into our second question, we wanted to look at the relationship between social determinants of health factors and hypertension levels in patients. Um, we looked at the city of origin as well as the food insecurity and found that both of these did have a statistical significance in artificial intelligence in patients in the underserved community, which means if the patient lived in a rural area and uses artificial intelligence device, we would possibly see either a compliant or non-compliant patient, not because they didn't want to use the device, but because of internet connectivity, not being able to transmit back to the EMR, as well as just not having the tools available to be able to toggle through the AI technology in the rural area. Now, food insecurity was also something that we looked at, and we were for sure that this was going to be a significant factor within the study. Food, logging your food. If you had a high sodium diet, this AI technology is going to tell you until the next few days, you would have a blood pressure reading of this much. So you would probably need to do some type of exercise, as well as drinking certain amounts of water and or watching your food intake and salt intake. So this played a factor in the additional variable that kind of helped the AI technology, because AI alone will not just help this population. I'm looking at research question 3. I'm looking at cultural backgrounds and related to the AI technology. We always hear that there is a specific culture, there's a specific ethnicity that is related to hypertension and or factors related to hypertension. So when we looked at these factors related to hypertension, we found that a lot of these factors are true, but we did find that it really doesn't really matter. The ethnicity, race, sex, the age is really significant. So a study did find that even though a patient did use a lot of AI, was eating healthy, fell into non-Hispanic, African American race with still high hypertension rates, that could be due to shrinking of the blood vessels, which boosts the hypertension rates in that patient. So that was an additional look into to find out why that AI would impact all of these factors at the same time. Research question 4, we looked at patient compliance on the hypertension levels. If that patient is eating correctly or going to nutrition class, and that patient's BMI. So One of the myths we can dispel right now is if you're overweight, you will have hypertension. A lot of patients who were overweight had very controllable levels, but the patients who ate a lot of sodium and logged a lot of sodium within these AI devices, uh, they had readings that were well above 140 over 90. So the predictive modeling stated that if I was overweight and I ate healthy, I was okay. But if I was underweight and I ate terribly, then the AI device will say, hey, your hypertension is way, way out of control. So a little discussion here when it comes to the AI devices, the SMPP. It addresses the main concern when you want to look at how can you reach the underserved populations, the vulnerable, the low income. Um, these devices were completely free, so it was easy for us to reach these patients because we received a grant for this. But the ultimate question in this discussion and the first bullet point is um, being able to access monitoring tools for free with the availability to access providers proved to be a great sign. So free devices, increased access to providers helped a lot of patients drop their hypertension. So I know AI is very expensive. So when you give them something to work for and to use to keep their levels down, patients really love to see those numbers decrease. Another emerging theme out of this entire study was a theory of planned behavior. Um, with that, the circle of culture played a big role. We would give this AI technology to a group of church women, and they will go to uh, a gathering on a weekend, and then they would walk 2 or 3 miles, work up a good sweat, take their blood pressure, become in range. But the theory of planned behavior says that even though this AI technology was saying they were going to be good, they started frying chicken, making macaroni and cheese, and different types of meals that were high in sodium that drove their levels way up. So AI technology stated that even though this patient was on a good path to have a controlled hypertension rate, this meal thrown it all off. So nutrition definitely plays a role in theory of planned behavior. Um, Even though this was not studied directly, the circle of culture theme is really the identity of a person. So um, that plays a really big factor than we even know about it, and it's going to probably be an emerging theme in the next few years. Of course, the limitations of this study, AI technology within a target population. So we could have got a lot more patients to participate, but when you're dealing with a certain type of patient in a certain type of community, a lot of things will come into play. One of those things is, do the patient even possess the capabilities of connecting to the internet and or a Wi-Fi hotspot? Most of the time, that answer is no. Using AI technology, is the patient educated enough to even know what AI technology is and if they can work the technology? That is also no, which plays a big role in patient education. A lot of patients just don't want their information floating around on a smartphone, in an EMR. So they rejected it just based on paranoia. So we did see a lot of patients do that. Um, with that education, as I stated before, the patients really need educating when it comes to AI technology, even on the most basic level as it relates to a hypertension or blood pressure cuff. They need a support system. The, the providers in the clinic cannot do it alone in a patient-centered medical home. They would need the community, a cousin, a family member to help them with this device to remind them to take their blood pressure because it's a continuous uh, take that you can do instead of waiting into your doctor's appointment. Um, Continuous program funding. As I said, we gave these devices free to the patients. They're not cheap. What happens when the funding runs out? Will we be able to supply our patients with these devices? Will we be able to get these AI technologies back from the patient once they start living a better life? Answer to that is probably no. Socio-economic factors, that plays a really big role in that as well. They'll feel like, oh, I don't have any money. I know it's free, but at some point I will have to pay for this AI technology. It may run up my bill. It may run up different aspects that I do not need at this moment. They need a new design on risk management requirements, as well as practitioner-patient relationship. Having that close-knit practitioner family is very important, as you want to make sure the patient is not in this alone, especially when using AI. And when you're using AI, a lot of the patients are going to be in the elderly range above 65. So you want to make sure you're guiding these patients, showing them how to use it, having frequent question and answer sessions, being available whenever they call and or email. So in conclusion, it is very important to implement types of AI platforms within the patient setting in the low income, vulnerable, and underserved communities. We saw increases in clinical decision making, information sharing, and streamlining processes. These information sharing was a big part of us because we were able to get compliant blood pressure rates sent to the patient's chart from the patient immediately. We were able to monitor the patient as many times as they took their blood pressure reading instantly and not wait for an appointment. We were able to make predictive analysis on if this patient will be compliant in the next 2 or 3 months or non-compliant. So the approach to population health with additional factors are very important. So AI alone will not cure the problem. You would have to focus on AI with other factors. We know it's a lot of factors that patients may bring in, but those combined together seem to work whenever you're talking about this population. The optimization and performance of this increase the clinical providers, improvement on quality, and speed of 100 decisions. So at the instant, we have a nurse working in the background, looking at all of these AI technologies, as well as the data and analytics team, and they're constantly pushing information, constantly looking at the algorithms. Anytime there's something that is outside of the norm, the provider gets an alert, a text, a call, and the provider's instantly calling the patient. Hey, what's going on? I see you have an alert. I see you have an issue. How can we help? Which ultimately helped improve healthcare accessibility when it came to mitigating shortages in the healthcare world. So we know that it is really tough to get healthcare providers, as there are a lot of travel nurses. There are a lot of people just retiring and moving out of the sector. So with this, it's a free monitoring system. The patient always has access to a team, and that team will never change or never rotate. So it's a very personal relationship that the patient has with the healthcare provider. So in conclusion, AI is probably the best thing that this population can have, especially when you're talking about having a clinic in Houston, Texas, and the patient lives 100 miles away in a rural area. And with that, I would like to thank you and ask if there are any questions.
That's it for today's general session. Before the other sessions begin, we will be hosting our town halls, which are open Zoom discussions around cutting-edge topics. Today's are titled AI and Pharma. How do we expect pharma to change? And ML on medical and health devices, edge versus cloud deployment. If you'd like to join one of these sessions and talk about the subject, use the link in the swap card session and turn on your camera. The session will be directed by 2 moderators and everyone is welcome. If you aren't crazy about Zoom discussions, we'll see you at our first talks beginning soon. Enjoy!